Right, so we briefly mentioned this last week when we did thyroidectomy. So in parathyroid disorders, there's only two problems. Either you have too much parathyroid activity or not enough parathyroid activity. Parathyroid glands, there are four. There are at the back of the thyroid glands. So their blood supply is connected to the capillaries in the thyroid gland. So therefore, they're inseparable. You cannot separate the thyroid gland from the the parathyroid gland from the thyroid gland. Right? It's just impossible because it's literally embedded there. But they are technically separate glands because they have a different hormone that they're secreting. They only secrete one hormone, which is the parathormone, or also called the parathyroid hormone. So this is a one-trick pony, a gland. So they only produce one hormone, and the effect of this hormone is to increase calcium absorption from the kidney, intestines, and bones, which raises serum calcium level. So therefore, the release of the parathyroid hormone is triggered by low serum calcium levels. Does that make sense? Okay. And as you know from A&P, there's always an opposite effect between calcium and phosphorus, correct? So when your phosphorus is high, calcium is excreted, and then vice versa. Okay. And that's their location. So that's what I mean by they're inseparable. You cannot pick them out. So therefore, any injury, including surgical removal of the thyroid glands, includes removal of the parathyroid glands. Let's go straight to the two disorders. Hyperparathyroidism. Since their only purpose is to produce parathyroid hormone, therefore any hyperactivity or overproduction of the parathormone because of hyperactive parathyroid gland activity causes what levels of calcium? High or low? High. So the only problem here is hypercalcemia. Of course, there are several consequences of hypercalcemia. Now for exam 2 and also for your quiz next week, I will only grab the manifestations from here. All right, page 1470. Are we clear? Or do you want me to go back to chapter, the fluid and electrolyte chapter? All right, so we'll just stick it with what's written here, okay, for the quiz and also the second exam. And I won't read it for you. These are the effects of too much calcium in the blood. Including what happens to, because where exactly did this calcium come from? Why did the serum calcium rise when you have high levels of parathyroid hormone? Where did that come from? From the bone, okay? And also increased reabsorption of calcium from the kidneys, okay? But majority came from the bone. So bones from literally your teeth and your skeletal bones. Okay, so that's where the calcium came from. So therefore, if calcium is broken down from the bone to increase serum calcium levels, what happens to the integrity of the bone? The teeth. Okay, so that's one of the consequences here. And with high serum calcium levels in the blood, then there will be risk of stones, kidneys, or in the ureters, or in the bladder. And other consequences include peptic ulcer disease as well as pancreatitis. Management. Well, if you have a hyperactive parathyroid gland, then one of the recommended treatment, well, there are different forms of hyperparathyroidism. If it's primary, which means you have, so let's review back here on the types of hyperparathyroidism. So if it's primary, then that means what's the problem in primary? Okay, the problem is in the parathyroid gland. Usually the cause is there's a tumor in there. Now, a tumor doesn't have to grow on all four of the parathyroid glands. A tumor in just one of them is enough to cause primary hyperthyroidism. Are we clear? All right, and then we have also here secondary. Secondary meaning it's caused by something else. Something like the most common secondary form of hyperthyroidism is from chronic kidney disease. Remember, this was actually mentioned in CKD. So one of the consequences of CKD is hypercalcemia, or it could also be the opposite, hypocalcemia, totally different cause. But for hypercalcemia in CKD, that's actually secondary hyperparathyroidism. So if it's primary, then the treatment is surgical removal of the parathyroid gland because there's a tumor, again, growing on it. Now, since this is surgical removal of the parathyroid gland, can this affect the thyroid gland therefore? So therefore, is the pre and post-op care for parathyroidectomy different from thyroidectomy? Exactly the same. Okay, because if you remove the parathyroid gland, are you also not resecting the thyroid gland? Yes. So we won't repeat pre and post-op care. It'll be the same, exactly the same as thyroidectomy. If the patient is not a candidate for surgical removal, then all we can do is manage hypercalcemia. So first approach, first option for lowering serum calcium levels is hydration therapy. Lots of hydration. Now, 2000 ml or more, can you do that in oral form, like in a short time? Is it easy to drink 2 liters? No, you'll be bloated, right? So therefore, if the patient has severe form of hypercalcemia, which means, what's the normal level, by the way, of calcium levels? 9 to 10, right? So let's say if it's severe, let's say we're talking 14, 15, that's severe hypercalcemia. You think we can take care of that by oral hydration? It'll have to be IV. So the patient will have to be admitted. And are there several risks there? So that's because again, I didn't read the manifestations. What are cardiac manifestations here? Arrhythmias. Okay, so therefore, what's your priority? Is it easy to lower serum calcium levels? So therefore, what's your priority? Lowering it or monitoring the heart rhythm? Monitor heart rhythm and then proceed with your interventions to lower serum calcium levels. So here are options. So hydration. Now, in actual practice, the hydration is actually not given alone. It's always almost given with diuretics. Now, there are details here, though, about which diuretics will be used to lower serum calcium levels. So along with IV fluids and also oral fluids, diuretics are used, but what do we avoid? Thiazide diuretics are avoided. Okay, but all that means what other diuretics are options therefore? Loop diuretics are okay. Mobility, because again, the bones here are weakened, correct? So additional stress on the bone will actually help strengthen it. So encourage ambulation, but we want to prevent falls, okay? Because falls can lead to fractures, but we want to encourage the patient to ambulate, okay? Keep moving, do light exercises, walking is great, but make sure they don't fall. And for diet, of course, we will have to modify, but look at the first statement. Okay, so we don't want to overdo it, okay? Because the patient does need calcium intake also. Now here, here's an exception here, of course, if there's a coexisting peptic ulcer. It was mentioned earlier that there is peptic ulcer formation with hypercalcemia. And hypercalcemia, as stated also in the clinical manifestations, this causes constipation, correct? Okay, so here are other options. Okay, so in the diet, you encourage high fiber or prune juice to help maintain normal bowel movements. And I won't read the rest of the nursing interventions. That's your responsibility. This will be very good in a select all and apply question. And how do you like the next gen questions you got from exam one? No, the drag and drop. Okay, so you're gonna get more of those. So we're gonna have the matching. Okay, they're just fun ways of answering questions. Okay. Or you have to like it because you're getting them anyway. And here's your patient education, basically patient teaching, especially during discharge. Any question? Oh, as far as diet, by the way, now it's not specifically mentioned here, but dairy products. Do you think milk, cheese are good for these patients? Why not? Aren't they high in calcium? Yes, but why are they not recommended? No, milk and dairy products. Sorry? Okay, very good. Any questions on hyper? All right, let's finish hypo. Oh, sorry, there's still a life-threatening complication here. So for hypercalcemic crisis, meaning severely high calcium levels, 13 or higher. Now, there are high risk for cardiac dysrhythmias. They could die literally in front of you. So for these patients, we require high rapid rehydration, normal saline or LR. Look at that, 100 to 150 ml per hour with calcitonin. Remember calcitonin from last week under thyroid problems? Okay. And there's the rationale for giving calcitonin. Again, it's the counterpart of the parathyroid hormone. So the opposite there, since parathyroid hormone raises serum calcium levels, the calcitonin will decrease serum calcium levels. Okay. So we have a synthetic form of calcitonin. Here are the options, diuretics together with the IV fluids. And you remember biphosphonates when you talked about osteoporosis? Okay, what do you remember about these drugs? What is your teaching for patients taking biphosphonates? Examples are alendronate, bisandronate. Does anybody remember? Remember, this is usually a weekly dose, 70 milligrams, or the patient can take it also 10 milligrams daily for 7 days. But most patients like the weekly option. They take it one time, once a week. And majority of the patients I know take it on a Sunday. That way they remember, oh, it's Sunday, taking my biphosphonate today. But what is the specific instruction when taking it? Anyone remember? Okay, too bad. So that will be on the exam. Again, there are specific instructions on taking, I'll give you one drug, alendronate. Sorry? For exam 2? Yes. All right, so I mentioned it, okay, and it's recorded here. You have to review biphosphonates, client education. How do they take it? Okay, what position in bed? And how much water are they taking it with? And what's the rationale for doing that? Here are some examples of biphosphonates, ethidronate and pamidronate. And that's about it. Questions? Okay, children. Let's do the opposite problem. So now this is now hypoparathyroidism. So if we had hypercalcemia and hyperparathyroidism, what do we have here? Hypocalcemia. So most common form again is primary, which is autoimmune, or it can also be secondary. Remember treatment for hyperthyroidism, wherein we destroyed the, especially surgical removal of the thyroid glands, then it will lead to hypoparathyroidism. It's also called iatrogenic. Yeah, remember the term iatrogenic? Okay. As a result of a surgical or therapeutic procedure. Manifestations of hypocalcemia, you still remember? What are those two signs? Very famous signs. Chavostics and Trousseau sign. Okay. And they're mentioned here. Also called tetany. Okay. So here's Chavostic and Trousseau. Management is the patient's low on calcium. So what do we give? Calcium. Okay. So the dosing, be careful with the dosing of the calcium because the kidneys cannot handle too much calcium at a time. So usual dose is 500 milligrams, and that's spread over throughout the day. So if the patient has an order for 1.5 grams of calcium gluconate, for instance, or calcium chloride, that will have to be divided into 3 doses throughout the day. Okay, meaning you don't give the 1.5 grams in one dose. It has to be spread out throughout the day. You can even give the last dose at bedtime. But for severely low hypocalcemia, the option, of course, is especially if the patient has signs and symptoms of tetany, Chavostics and Trousseau, then they'll be given IV calcium gluconate. And with any calcium supplement, what do we always give it with? Vitamin D. Okay. So here are the combinations. Remember, vitamin D is ergocalciferol or calcitriol, because there are 2 forms of vitamin D. It's either activated vitamin D or inactivated vitamin D. Okay, that's in the form of ergocalciferol or calcitriol. Those are your vitamin Ds. And here are your nursing care, because the patients here with hypocalcemia are at risk for seizures. So institute seizure precautions. And for diet, here we go. So here, why is dairy products not encouraged? Why are they avoided or restricted? Please read. What's wrong with them? They're high in calcium, but what are they also high in? They're also high in phosphorus. So this will defeat the purpose. So they take them, but because they have high phosphorus content though, so will they raise the serum calcium level? No. And then same thing for spinach. So this is a very good test question here. All right, just letting you know. I can think of 3 different ways of asking. And here are your other options for acute hypocalcemia. So same thing as in addition to calcium gluconate. Questions? Alrighty. And here are your patient teachings. That's the end of parathyroid glands, parathyroid disorders.